guys for having me. My name is Christy Forsmark. I'm in charge of the Ventricular Assist Device program at University of Colorado Hospital. Many of you, if you've participated in this conversation in the past, may have heard or seen these slides before, but we feel like these are such low volume patients and high risk that it's great to hear the information as many times as needed. And I'm happy to answer any questions as we go. I can't see the chat as I'm presenting for some reason, but if you want to come off mute or raise your hand or put a message in the chat if somebody wants to stop me if they can see it, or we can wait till the end for questions. So I'll go ahead and get started. You will notice that on every single slide that I show you, we have our 24/7 LVAD hotline. This is where you reach one of our on-call RN VAD coordinators who is available to help you at any time of day, any day of the week with our patients. And part of our job is to support patients outside of the hospital. They often call us and we often hear from them before you guys hear from them. We may say, hang up with us and call EMS, call 911 and get someone coming to you that can help you. We are going to be your best support. And if you remember anything from this conversation today is that you should reach out to the VAD team and we will help support you. We really know these patients well, so we can also navigate the intricacies of each patient's individualized care and their VAD care. So our objectives today is just a brief overview of congestive heart failure, indications for mechanical circulatory support. You will hear me say LVAD, you will hear me say VAD, you will hear me say MCS. I am talking about the same thing. It's durable mechanical circulatory support. That means a pump that patients can go home with and it treats advanced heart failure. So we're going to talk about what devices we have that support advanced heart failure. We're going to talk about monitoring the patient when it's when we consider it's an emergency with the VAD, and then how, again, to contact us, which I've already told you, but we will continue to talk about that throughout this. I like to start with a slide of this is probably pretty close to up to date of our catchment area. As you can see, most of our patients live along that Metro Denver south and north I-25 corridor, but we do have patients in more rural areas, as you guys know, out east in western Kansas, Nebraska, Wyoming. On the western slope, we have patients also in New Mexico, and then in southeast Colorado as well. So we're kind of have patients all over the place. And the one thing that I like to really share when I'm presenting about our patients is that we're the only durable VAD center, VAD and transplant center in Colorado for adults. Children's, of course, can manage VAD patients. They don't manage a lot of VAD patients, especially outside the hospital. But for adults, we're the ones. And we manage patients, as I said, from Wyoming, Kansas, Nebraska, New Mexico. We've had patients in Montana. We've had patients in Nevada. But we're really good at managing them from outside the hospital and far away from us, not necessarily right in our facility. And as you can see from this map, we are really the most geographically isolated VAD program in the continental United States. And we feel pretty proud about our capabilities of managing these patients and helping you guys manage them outside the hospital if needed. So a little bit about heart failure. There's a lot of heart failure in the United States. More than 50 million Americans live with heart failure, and approximately 50% of them die within 5 years of diagnosis. So it's pretty deadly disease. The patients who get LVADs are patients who are at the end stage of their heart failure. They have sorry about that, class 4, NYHA class 4 heart failure symptoms. That means they have heart failure symptoms at rest before they get their LVAD. Once they get their LVAD, our goal is for them to improve their heart failure to that NYHA class 1 or 2. We really like to talk about LVADs and spread the word about LVADs and really about all advanced heart failure therapies, including LVADs and transplants, because there's a lot of patients out there who could use these therapies. And patients who meet criteria for LVAD, they're the sickest heart failure patients. And when they meet that criteria, only about 17% of those patients are alive at 1 year. On the contrary, if those patients get an LVAD, about 85 to 87% of those patients are alive at 1 year. So LVADs can really increase mortality, which is great if it's the right thing for the right patient. Of course, that's not always the case, but our hope is that patients who need LVADs get LVADs, and we're able to support those patients living with those devices. Hopefully, most of the time, living well in the community without any problems. However, sometimes they encounter problems, and you guys all become involved. So a little bit more about heart failure. In case you don't know, we classify heart failure symptoms with the New York Heart Association classification system. And again, these patients, when they get an LVAD, they have really bad heart failure. They have that heart failure symptoms at rest. Like they can't even eat dinner without being short of breath. They can't sit there and watch TV or brush their teeth without having these heart failure symptoms. So it's really hard to function in a really poor quality of life. So some indications for MCS or LVAD. We sort of, and you may have heard of different indications like a bridge to transplant LVAD or a destination therapy LVAD. And to be honest, the reason why the patient has an LVAD or the indication the patient has gotten an LVAD to you guys in most cases is irrelevant. They're a patient that needs your help and they have an LVAD. So their indication is irrelevant, but I think it's helpful for you guys to understand how patients get to LVADs and how sick they really are when they do get their LVAD. Again, they have that NYHA class 4 heart failure. Their ejection fraction is less than 25%, less than or equal to 25%. Most of our patients have an EF or an LVEF of like 10%. We had a lady we evaluated this week for LVAD and transplant whose ejection fraction was 8%, and she walked into clinic. And, you know, she's somebody who's had heart failure for a really long time. And so her body's kind of gotten used to that. But it's really amazing that these patients are even able to, you know, leave their house with their heart failure. It's so bad. They need to be inotrope dependent, or they need to have a cardiac index less than 2.2 while not on inotropes, and have been tried on optimal medical management and are failing that at least 45 of the last 60 days, or are dependent on some type of acute mechanical circulatory support. That's like a balloon pump or an Impella or ECMO, all of those acute devices that we use only in the hospital. So that's sort of our indications and how sick these patients are. So what is a VAD? A VAD is a pump that's implanted with connections from the left ventricle to the aorta, diverting most of the cardiac output. This device does not cure heart failure, but again, like I said, it improves our patients' exercise tolerance, functional capacity, and overall quality of life, hoping to return them to a New York Heart Association class 1 or 2. Class 1 heart failure is patients really have no heart failure symptoms. They have heart failure, but don't have symptoms. Class 2 is very mild symptoms. The device is implanted in the body, again, just below the ventricle, and is connected to an external drive line that comes out of the abdomen and attaches to a system controller. It's a small computer that can be the brains of the device, but really it's the information center. It's where we can look at the numbers, the VAD vitals, and see what's going on. If there's any malfunction with the VAD, there will be alarms. If there's an alarm, it will illuminate certain colors and certain pictures on the controller, and the controller will have a message of what's going on with that. So the controller is important, and it stays connected to this patient at all times. It should never be disconnected without talking to the VAD team first. And that is a great place to look for information while you're contacting the VAD team, so you're prepared to talk to us. Again, this pump it's electrically powered. It's a continuous flow pump. It's either spinning in an axial or centrifugal fashion. The pump function is confirmed by auscultation of the upper left abdomen or lower chest. So if you're unsure the pump is spinning, you should be able to put your stethoscope onto that patient's chest and listen. If you hear that pump spinning and there are VAD alarms, there's absolutely no indication to change anything about that. You want to get us on the phone and talk to us about what next steps are for that patient. There is no manual backup device. These system controllers have redundancies, and I always include that in my talks, especially to EMS, as there's often people who have been involved in EMS for, over 20 years, and they may have heard of our pumps, the original pumps that had a hand pump, really, that would be connected to the device when the controller failed. This is our first generation LVAD. Our LVADs are much more durable and have redundancies, so they don't fail like that old-fashioned original pump did. But these devices don't need the hand pump anymore, so that's great, much more reliable. We have 3 current durable VAD pumps. Can you guys still hear me?
Yeah, we can hear you.
Yes.
Okay, thanks. I just got a message that my internet was funky, so I just wanted to make sure I wasn't just talking and talking. Thank you. So we have 3 pumps that we are still currently managing, the HeartMate 2, HeartMate 3, and HeartWare HVAD. They look a little bit different on the outside, but for all intents and purposes, these patients are going to be treated by you guys the same. We're going to make sure that they have their backup equipment with them. All of our patients are given these backpacks that you can see in this picture here. They should have their backup equipment, at least a few extra batteries, and the backup controller if they would ever need it for some reason. They're instructed to bring that with them every single place they go. If you're being called to these patients' home and you're transporting them from home, you will probably see these units at the bottom, which are their battery chargers with some extra batteries. You might see a wall unit. What we always recommend for EMS is to get all of their equipment that they have with them, especially if they're going to a hospital that doesn't support VADs. So if they needed urgent treatment, they couldn't get to University of Colorado Hospital, we would suggest bringing them to the nearest hospital where they could receive the treatment they needed. And if that's the case, they're not going to have extra equipment. So we always say if you see the equipment, get it, bring it with them, and make sure it follows with them wherever they go. The top pictures are the controllers that I spoke about. Those are those computers that give you further information. The good thing to know is there are some buttons on these controllers. The most important one is that that alarm silence button. If the VAD is alarming, you push that silence button and that just shuts the machine up for a second so you can give us a call and we can talk through what next steps are. None of the buttons, if you push them, will make any changes to the device settings, so you never have to worry about that. So emergency response for these patients. Again, we spend a lot of time with these patients after implant and provide them and their caregivers a lot of education. So they're prepared to call us 24/7 too if they're having a problem. So a patient is instructed to call the VAD coordinator when they have any questions or concerns. If they have a fever, they have any signs of infection at their driveline exit site. Again, that's that cord that comes from inside their body that's connected to the pump outside to the controller that helps connect the pump to power and gives us information. If they're having any device alarms, if they have their ICD fire, I'd say 99% of our patients have had heart failure long enough that they've got an ICD and a pacemaker. So if that ICD is firing, they're going to give us a call if it's just at one single fire. If they have a weight gain of 3 pounds in 2 to 3 days, any kind of heart failure weight gain or signs of heart failure like shortness of breath, dyspnea on exertion, orthopnea, they have any change in the trend of their device vitals or their VAD vitals, or if they have any equipment problems. So those are all the reasons we train our patients to call us. They call us for those and many more reasons, which is great. We instruct them, however, if they're having any medical emergency that you would typically call 911 for, we instruct them to call 911. They have major alarms on their LVAD and that's new for them or they're symptomatic, we ask them to call 911 and get somebody coming to them if their ICD is fired multiple times, we want them to have somebody who can treat them, come to them. Our instructions are usually call EMS and then call us. And like I said, we often will, not often, but when we do need a patient to call EMS, they've usually called us first and we're saying, hang up and call 911. We'll call you right back, get them on the way to treat you. Any change in neurologic status, these patients are prone to stroke. That's one of the common complications that we're always concerned about with these patients. So any changes, we talk to them about identifying stroke. We make sure they're well aware of how to do that and to call us immediately with any of those symptoms. Or if they trip and fall and hit their head, if they hit their head for any reason, these patients are anticoagulated. We want to know about it. They're just more prone to those head bleeds after strike. So we may send them into the ER if they call and say, I fell and hit my head. I feel fine. We're going to say, you know what, why don't you go to the ER and get your head scanned just to make sure. And because we've more times than you'd think have found bleeds in brains just from a routine head strike. So we're super cautious with that. So that's why we would ask them to call EMS. And then this is what we would expect. So we expect you guys, just like you would with any patient, is to stabilize and transport. These patients are appropriate for ACLS if that's required. They should have IV access. They could be hypovolemic even though they are heart failure patients. That's sometimes one of the biggest complications we have with these patients. Hypovolemia could be related to blood loss, overdiuresis, not drinking enough because they're heart failure patients and they just don't do that. So volume is appropriate for these patients. Rely on family to handle VAD equipment upon arrival. It's really helpful if they have a family member or caregiver that's there. If they could get in the rig with you guys and go, that's probably the best option because they're going to be able to support you with the equipment. But most importantly, we want you to call us. Call us and we are going to help you guide the care of this patient. Like I said, we know these patients better than anybody does. We see them very frequently. We spend a lot of time with them and we know them well. So we can help guide you to care for these patients, even during an emergency. We have an EMS protocol that we've worked with various agencies to create several years ago. We've recently updated it to make sure it has the correct phone number. The one in this slide does not, but our current one does. So I'm going to make sure you guys all have our correct VAD hotline phone number. If you guys have a VAD number for any reason, please confirm that it's the one that's up here in this red box. Sometimes I run into EMS and they say, oh, I have the VAD number in my phone and it's our old number. So that's a pager. It does not work. We use the VAD hotline in which you would call the operator at the hospital via the VAD hotline and they would connect you to us or they would get your phone number and we would call you immediately back. So this algorithm really tells you to assess the patient as you normally would. Signs of perfusion, cap refill, make sure their heart rate is, they're hemodynamically stable. Cardiac monitor, they should have, their heart is not fully taken over by the LVAD. The heart is still in there beating, so appropriate to assess the rhythm, pulse ox, blood glucose. If the patient is stable, you're going to address any medical problems and transport to us at the university if possible. And then always, again, contact the VAD coordinator. If they're unstable, you want to first determine if that VAD is running and functioning properly. And like I said before, you want to listen to their chests. You want to look at the VAD controller to see if there's any alarms, lights illuminated, or sounds. If the VAD is running and they're unconscious without perfusion, you would consider chest compressions. If their rhythm requires, we would consider defibrillation. You're going to consider fluid bolus, and then you're going to let the destination know that this is a VAD patient. Again, you would be getting us on the phone to support as you're supporting the patient. If the VAD is not running and the patient is unstable, same, you're going to support the patient however they are. That's really important to contact the VAD program at that time. If you think the VAD is not running, reach out to us. We've had a handful of times where a VAD controller has been changed in the community and probably didn't need to be, either because the patient was telling EMS it needed to be changed, or because there was an assumption made because there was alarms that it needed to be changed. That is usually not the case. These controllers rarely just fail. So you want to talk to us, support the patient, get the VAD team on the phone, and we can help determine the next best steps to get that pump running if it's not running. Again, the key points, here's our correct number on this portion of the pathway. Make sure that you reach out to us. For pediatric patients, there's a phone number. For Children's Hospital, as far as I know, they rarely discharge durable VADs into the community. They rarely implant durable VADs. They're usually supporting the kiddos in-house on temporary support, or if they do get a durable VAD, then they're supported in-house on that durable VAD until they can get to transplant. But if it was a pediatric patient, you would want to contact the Children's Hospital transplant coordinator via that number that's included there. Again, we are always hopeful. A best case scenario is the patient has their backup equipment, any extra equipment you see, and they're transported to UC Health. I have a question. I can see any concerns or guidance if chest, yeah, absolute chest compressions are appropriate, and when necessary, if they need chest compressions, then they need chest compressions just like anyone else, and they should be done as you would for any other patient. The one recommendation I always share is a Lucas device at this time is not recommended, or any of the automatic compression devices. However, I like to say that, I was an EMT before I was a nurse 100 years ago. And the one thing I remember is that you always want to make sure the scene is safe, or really, and for me, that goes for the whole time. If you're running a code from, an hour away, you're not going to do compressions for an hour. You're going to put the Lucas device on these patients, and that's okay. So you want to make that decision. Is it better for everyone involved to have the Lucas device? But just to use it is not recommended at this time. Again, use it if you need it. Don't use it just because you have it on these patients, is what we recommend. So things to keep in mind: use the patient's report of symptoms as your guide. The system controller will alarm if it has any problems. Frequent or sustained alarms are more concerning than brief or self-resolving alarms. And for me, frequent and sustained alarms that our patient is symptomatic with are even more concerning. If a patient's having alarms, but they're not symptomatic, they're usually calling us, and then we're probably going to see them in clinic and do some evaluation, or maybe send them to the ED. But if they're symptomatic, we might have them call EMS and get you guys going there so we can get them to the hospital faster, get them treatment faster. Their perception and symptoms are the most powerful indicators of their condition. Just like a regular heart failure patient, treat them that way and you can't go wrong. You're going to always call the VAD team. Again, if you get anything out of this conversation, you want to give us a call and we will support you. We're literally, that's our job, is to support caring for these patients in the community. So in the very beginning, I showed you a video of how the pump connects to the left ventricle, and it pulls the blood from the left ventricle, and it ejects that blood out through an outflow graft that connects to the aorta. When that happens, we are bypassing the aortic valve, and we have a continuous flow device. So what happens in that instance is our patients are no longer pulsatile, meaning you're going to assess their pulse or their perfusion a little bit differently than you would if their VAD is running. You're going to assess their perfusion a little bit differently than you would a patient without an LVAD. They will unlikely have a palpable pulse. They may have a palpable pulse, but it might not correlate with your EKG rate. So that may not be helpful. They need their blood pressure assessed slightly differently than regular patients. And I'm going to share a video, and it's because of that bypassing of the aortic valve. I'm going to share a video if you can give me a thumbs up. I think I shared sound, so you should be able to hear it. If somebody can just give me a thumbs up once this starts, that'd be great.
Blood pressure measurement in a person supported by a continuous flow blood pump. Let's take a look at the
Did you hear the sound?
Yes.
Oh, good. Thanks. I'm going to keep it going then.
equipment that you'll need. You will need 3 things to be able to measure a blood pressure: a Doppler, a blood pressure cuff, conduction gel, and of course, the person supported by a continuous flow blood pump. The first step is to find the person's pulse with the Doppler. You'll need to start with the conduction gel. Place conduction gel on the inside of the person's elbow along the crease. Now it's time to find the person's pulse. Turn on the Doppler using the power button. You'll know it's on when you start to hear noise coming from the speaker. Put the free end of the Doppler's wand into the conduction gel you placed on the inside of the person's elbow. Slowly move the wand back and forth until you hear a swishing sound. You may hear an intermittent swish, 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 or it could be a continuous blowing sound. Either way, it should be a distinct sound and not caused by movement of the wand. The sound you hear is the sound made by the person's pulse. Now it's time to place the blood pressure cuff on the person's arm. Place the cuff on the person's arm just above the bend in the elbow. Make sure the gauge is facing front. You'll need to use the Doppler again. Don't be afraid to ask for help holding some of the equipment. Find the person's pulse again before you blow up the blood pressure cuff. Now blow up the cuff using the bulb. You will have to turn the round valve so the air doesn't escape. Continue to squeeze the bulb until you don't hear the pulse anymore. Then squeeze it 2 more times. Make sure you keep the Doppler probe in the place where you heard the pulse. Now turn the silver valve and slowly let air out of the cuff. Watch the needle on the pressure gauge while the cuff is deflating. Listen for a return of the pulse as the cuff deflates. When you start to hear the pulse again, the number the needle is pointing to is the number that you need to record. Here, it was 90. Did you miss it? Let's look at it again. You can also find the patient's pulse on the inside of the wrist, over the radial artery. Again, the pressure that you record is the number that the needle is pointing to on the blood pressure cuff gauge when you start to hear the swish. Some centers call it mean arterial pressure, MAP, or MAP. Others just call it blood pressure, or BP. In this video, the place where we heard the first swish, or pulse, was at 90 millimeters of mercury. Did you miss it? Go back and look again.
All right, so that is the unique way that we check our patient's blood pressure. We do supply a blood pressure cuff and Doppler, and they're instructed to keep that with them in their emergency bag. Do they always? No, but that's their instructions so that they have it wherever they go if they needed to check their blood pressure. Blood pressure assessment, especially in patients when they're having certain alarms, is important because it can help guide us to why they're having those alarms. Our newer pumps, our HeartMate 3, some of our patients are sometimes pulsatile, meaning you can feel their radial pulse with every beat. And you can assess that by either listening to their heart rate and getting it and comparing that to their palpable pulse, or by putting them on an EKG monitor. And sometimes those patients benefit from an automatic cuff. The most important thing to know is if you put an automatic cuff on these patients and it gets a number, the pulse pressure will be a lot narrower. and it'll likely be a lower number. So we don't ever want to be worried about the automatic blood pressure. If it's reading, we want to be able to check that Doppler blood pressure or Doppler map. And then the other part of that is if you did an automatic blood pressure and it didn't read, it does not mean they have low blood pressure. It just means they're not ejecting out of that aortic valve. So now I want to just talk a little bit about the types of problems we see with our patients, the common complications, and then what do we do when the device fails or if it fails? It's again really rare, but we'll start with the pathophysiology. So I call these patient problems. Common complications with LVAD patients are stroke. It could be a hemorrhagic or embolic. This patient has their blood flowing through their this big metal pump in their body 1 million times a day. They are anticoagulated, so they can have anticoagulated coagulation complications. So those kind of go together. If a patient has signs of stroke, like I said, they are instructed to call EMS and get somebody coming there, and they should go to the local center. If they are a candidate for any kind of treatment, we want them to get to where they can get the treatment as soon as possible, with the idea that we would transfer them to our center as soon as medically stable once they've received that treatment. Patients with an LVAD can be hypovolemic, which is different for heart failure patients. They can be dehydrated because of overdiuresis, again, not drinking enough, or blood loss related to anticoagulation complications. They can have anticoagulation complications. That's usually bleeding. A lot of GI bleeding we see with these patients, nose bleeding. We have a current patient who calls EMS a lot for a nosebleed, and it's usually stopped by the time they get there. But he can't quite figure that out yet, and I think it scares him, so he's often calling 911 for that. That is not our recommendation. We have a lot of instructions around nosebleeds, but they could have a nosebleed bad enough that they might need embolization, so they can be bad. These patients can have continued heart failure, and they can have right heart failure. This pump is meant for their left ventricle and supports patients with left ventricular failure. So RV failure can be a problem. And if a patient has RV failure and it's not, their heart's not moving their blood over to the left side where their pump is, it might not work as well. Hold on one second. Dad. Sorry about that. Can you hear me still? I'm here with my dad. We had surgery. They can also have infection. That's an isolated infection at the driveline site, or they can become septic from this. So we want to really make sure that we're managing that driveline site and making sure their equipment's moving with them. If they're passed out somewhere, you want to make sure you got that controller and got that bag that's carrying the controller, and we're not letting that drop or hang off the gurney as we're transporting them. And then they can have hemolysis, which would be a thrombus inside the pump. That will cause the pump not to work correctly and can also lead to that embolic stroke that we talked about. So a lot of these infections really, or a lot of these patient problems really go together. And these are the most common patient problems we see related to the VAD. They can have any other patient problem that any patient out there in the world could have. And you may see them for something totally unrelated to the device or their heart failure, and you would treat them as you would treat any patient with any problems. So treating a device failure, the first thing you want to figure out is the device really failed? And remember, I told you the best way to do that is to listen to their chest and see if you can hear that whirring of the pump. These pumps are spinning anywhere from 24,000 to 10,000 RPMs, depending on the device. So you can hear it very obviously inside their chest. So if the device fails and you've confirmed it's failed, you're going to treat the patient. If the patient is responsive, you're going to support them medically, just like you would any patient without an LVAD. If they're awake and alert, or awake but not doing great, you're not going to do chest compressions on an awake patient. You're going to support them. Inotropes are usually your best bet if the pump has failed. If the patient is unresponsive, you're going to assess their perfusion without the VAD, and you're going to initiate ACLS and cardiac and respiratory code them as you would any patient without an LVAD. Medically support them with inotropes and transport them to the nearest facility. If the device has failed, if you hear the device, if you listen and the device is off, that is a great time to get a hold of the VAD team, because we can help you further assess if there's a way to restart the device. And we would recommend that in the instance that the patient, wasn't, I guess, warm and dead is the right, or cold and dead. I don't know. They're not dead until they're warm and dead. I don't know. We have a response. We have several different algorithms. And really the EMS algorithm is the one you guys want to follow, but we have a red alarm algorithm that really is assessing if the pump is working, if the patient's responsive or unresponsive. If they're unresponsive, we have a resuscitation algorithm. And if they're unresponsive, again, you're going to figure out if the VAD is functioning. If it is functioning, you're going to support the patient with ACLS if they're not perfusing. If they're unresponsive and they're perfusing, which means their MAP is greater than 50 or their end-tidal CO2 is greater than 20, then you would not do ACLS because they're perfusing. You would support the patient in other ways. They could be unresponsive for, who knows what, but you want to make sure you evaluate their perfusion when the pump is functioning. If it's not functioning, it's a little bit easier to evaluate their perfusion because you would do that just like a patient without an LVAD. Again, cardioversion and defibrillation are appropriate for these patients. You do not have to disconnect anything. You would do it just as you would any other patient, and same with chest compressions. So lastly, we want you to call us, as I've said a million times. Automatic blood pressures can be inaccurate and unreliable. You may not get a measurement with an auto blood pressure cuff. That does not mean the blood pressure is low. If there's a caregiver nearby, they're likely well trained and they can be helpful with the equipment and making sure that we've been contacted. Arrhythmias will reduce pump filling and overall cardiac output. They may be treated by electrical cardioversion or defibrillation. Patients are all anticoagulated with aspirin. Some of them, we've actually removed a lot of aspirin with the newer pump, which is great, but some of them still take aspirin. They all take warfarin. Caution with bleeding, INR goal is 2 to 3. And the VAD system must always be powered by 2 batteries or a wall unit. If you disconnect that power, the pump can stop. So if there is a reason to change power sources or you have any concern about that, that's a great time to get the VAD team on the phone and make sure that we can support you with those changes. We have been in situations where we've had to get on FaceTime with EMS to help with equipment. We're always happy to do that. Just call that VAD hotline and we will call you back shortly. And then very lastly, I wanted to share, there are a lot of resources out there for VADs. I can send you these links separately so that you have access to them. We have the International Consortium for Circulatory Care Clinicians, Circulatory Care Device Clinicians website that has LVAD emergency guides. These are available to anyone and has really a very similar algorithm to what I shared a few slides back for our EMS protocol, and then has some very specific instructions for different devices. I think it's a really good device, but that's where you'd be getting the VAD coordinator on the call and getting us to help you help the patient. We also have Abbott and Medtronic, the 2 different devices that we still manage, manufacturers. They have a lot of videos on their website, and you are able to access those and look at that and get a little bit more information than I provided tonight. And that's all I have. I see there's another question, Dr. Farkas.
Oh, no, I was just clarifying
Okay.
that the numbers on our protocols are actually the old ones. So thank you for bringing
Yeah.
that up. We will
Yeah.
update it and send it soon.
Yeah, I've tried to get it out there into the world as many different ways. I give presentations to several different EMS companies or EMS platforms, and I know you guys are a lot of different people. And I just can't seem to quite get it to everybody. So share that widely. Our pagers went away about 2 years ago. Our patients, every patient has stickers on all of their equipment with our current number. are given a bracelet. They don't all wear the bracelet. A lot of them put the bracelet on their backpack, etc. So we are the people you should contact. Let me see. There's another question. Is there any concern for device damage from defibrillation? No. No, we don't worry about defibrillation. Internal defibrillation. So if the patient's chest were cracked and we're using the internal paddles, we are a little bit concerned about that, but you guys should never be doing that. Hopefully no one's ever doing that, but if that's the case, that's the only time we're concerned. For worsened heart failure, is non-invasive positive pressure and nitrates still the best treatment modality? It would treat them just like any heart failure patient. They're likely on a lot of heart failure meds already. Yeah. Anybody have any other questions? You can come off mute and ask me. You can always email me if you have any questions or concerns. Dr. Farkas, I'll send you those links that are on the end of this PowerPoint so that you can share them with everyone, or
Yeah,
somebody
that'd be
can share
great.
them.
Thank you.
Mhm. Does anybody else have any questions, concerns, experiences you want to share?
Awesome. Well, thank you so much for doing this.
Yeah.
It's always a nice refresher for me also.
Yeah. Yep. And I'm always happy to do it. And, I'll talk to you guys again next year, or if you need anything sooner, I'm happy to do that too.
Thank you. Have a good night, everyone.
Thanks. Bye.